Good morning, everyone, and thank you for joining today's webinar covering the all-new primary care first model. My name is Rudy Alnell. I'm a software trainer here at Persivia, and I will be your host for today's session. Today, we will get a chance to kind of understand the PCF program. We'll also discuss the strategies for your successful participation in the program. Before we dive deep into it, there are a couple of things that I would like to bring to your attention. If you have any questions during the presentation, please just type them into the question box in the GoToWebinar control panel, which you'll see on the right-hand side of your screen. I'll bring these questions up during towards the end of the session, and our presenter will answer them for you. In addition, we will send you the slideshow and the webinar recording after the session. Now I will turn the time over to our presenter, Dr. Fatima Baloch. She is the product owner of our clinical quality dashboard at Persivia. Dr. Baloch has years of experience in managing regulatory requirements and has been helping the team and our clients successfully report quality year after year. So, Dr. Fatima, if you're ready.
Thank you, Rudy. Thank you, everyone, for joining. Today, we will go over the Primary Care First program, which is an initiative by the CMS Innovation Center. And during this webinar, we will go over the design of the model, the goals, what are the eligibility and requirements for PCF's general component, how PCF and CPC Plus are different from each other, and then what are the requirements for quality gateway measures. We will also go over how Persivia can help you succeed in quality improvement metrics for PCF program, and then we'll wind everything up with a Q&A session. CMS Innovation Center has always focused on ways to improve care and reimbursement to primary care providers and practices. And in continuation of the same efforts, the PCF program was launched. The idea behind was to reduce expenditure by reducing hospitalization and ER usage while improving care to the patients and the outcome. This is a voluntary program and it will run its course for 5 years. Cohort 2 started in January 2022, and this year CPC Plus clients can also join in and report on PCF. PCF has been built on the foundations of CPC Plus and focuses on physician-patient relationship and how that relationship in turn improves the all-over care that is provided to the patient. Like CPC Plus before, PCF is also a practice level reporting program. However, the model moves from fee for service to performance-based payment model. And what this change does is that it improves the incentive and offers flexibility to the providers to impart care based on the unique needs of each patient. The quality of care provided is assessed by CMS by using a preset measures that they release, and meeting the benchmarks of those metrics would find a provider eligible for a positive performance-based adjustment. The measures that were selected by CMS are controlling high blood pressure, diabetes, hemoglobin A1C, poor control, and colorectal cancer screening. These are the ECQMs that were selected for gauging the performance of PCF practitioners. Now, with this shift in the program from CPC Plus to PCF, what CMS is trying to achieve is that physicians are relieved of the burden of unnecessary documentation, incentivization of providing better care, especially for the patients with complex or serious illnesses, and this also helps in improving all-over patient care. Patients should ideally feel more connected to the PCPs that are participating in PCF program, and that would also in turn help reducing ER usage and hospitalization. And now, very similar to CPC Plus program, PCF also has the 5 core function that CMS describes as advanced capabilities of care. The access and continuity is very vital for all patients. The idea is that patients should have 24/7 access to a member of the care team, and this does not have to be face-to-face. It can be anything from telehealth, emailing, texting, or any other communication methods that a practice can implement in their system. Next is care management. Practices and providers must develop techniques for advanced care management. And now this can range from enrollments, providing long-term, short-term care based on the risk of the patients, follow-ups, medical reconciliation, or using the data to risk stratify the patients. Next is comprehensiveness and coordination. The practices must think holistically about what the patients need and how to coordinate it across the healthcare system. And this would include specialized care. So with relationships between primary care and specialists, the goal will be to provide a better care for the patient at the end. Next is patient and caregiver engagement. What this means is that using the patient and the caregivers in achieving better health by self-management, and that can be through education, giving them incentives to help improve their health. Next is planned care and population health. This core feature encourages practices and providers to see where improvement is needed, how to stay on track on the things they're good at, and how to set new goals and achieve better health for their patients. Now, what is the participant eligibility and requirements for the general component of PCF? The first and the most important one is that a practice should be part of the primary care first region. Those are the 18 regions from the CPC Plus program plus additional 8 regions, so a total of 26 regions. So practice being in any of those 26 regions can participate in PCF. The practitioners have to be primary care practitioners, which are doctors of medicine, doctors of osteopathic medicine. They can be clinical nurse specialists, nurse practitioners, or physician assistants. Also, a practice must have a minimum of 125 attributed Medicare beneficiaries to them to be able to participate in PCF. And a practice's revenue has to be on account of primary care services, and at least 70% of that revenue should be primary care services. The practice should also be using a 2515 edition of certified EHR technology, and they must attest that they do provide advanced primary care delivery capabilities to their patients. Next, we'll see how PCF compares to CPC Plus. In terms of the revenue as compared to other Medicare payments for PCF, the revenue is the same. A PCP will only receive more revenue if they reduce hospitalization as compared to other PCF practices, or they decide to specialize in patients with high risk scores. However, under CPC Plus, all practices received higher payments than the regular standard Medicare payments, regardless of how they were performing on quality and utilization measures. The monthly payment per patient is the same for PCF, regardless of the individual needs of a patient. However, if the entire patient panel of a practice has a higher risk score, then there will be a higher monthly payment for each patient. In CPC Plus, however, the patients were receiving a higher payment based on individual patient. So if an individual patient had a higher risk score, they were receiving higher payments, but that it will not be the case with PCF. Under PCF, the patients will get better palliative care services because the payments are higher for seriously ill patients because their risk score is higher. However, under CPC Plus, that was not true, and the payments were not higher under the care management fee for CPC Plus. Also, by standardizing the cost for the primary care visit. Uh, the PCF program is achieving improved outcomes and decreasing costs, whereas in CPC Plus, the practices were being paid more based on the complexity of the visits. And as I mentioned earlier, by reducing ER and hospitalization, PCF practice will receive higher payments. And whereas in CPC Plus, the practices were receiving higher payments based on the high practice performance on its measures. And then coming to the measures, let's take a look at the quality measures for CPC Plus and PCF. So for CPC Plus, there were hemoglobin A1C poor control measure, controlling high blood pressure measure, and a CAP survey measure. For PCF, risk group 1 and 2 will have the same 3 measures, and then also colorectal cancer screening measure and advanced care plan measure. For PCF, risk group 3 and 4, advanced care plan measure and CAPS measure would remain the same with an additional days at home measure. Now, how are the risk groups assigned to a practice? That is solely done by CMS, and it's based on the average HCC risk score. So any risk score less than 1.2 is group 1, 1.2 to 1.5 is group 2, 1.5 to 2 is group 3, and greater than 2 is group 4. Now, what are the requirements for the quality gateway measures? Now, since PCF provides flexibility to the practices to implement strategies to reduce ER and hospitalization usage, the quality gateway measures are a way for CMS to gauge if the practices are meeting the threshold for the quality of care. For risk group 1 and 2, the practices must meet the minimum threshold of the 5 quality measures, and a minimum of 30th percentile for each measure must be achieved. Practices in risk group 1 and 2 are required to successfully report on all 3 ECQMs, and if a practice fails to report in any of the measures, they will fail the quality gateway part of the PCF program. And the benchmarks for these are based on 2021 MIPS benchmarks. And the practices will be participating, whoever are participating in cohort 2 will be through January 1st and December 31st, 2022, and the reporting period would be January 2nd to February 28th of 2023. CMS will calculate these measures annually, and the practices are required to report 12 months worth of data for each of the ECQMs. Now, for the advanced care plan measure, which is a claims-based measure for 2022, CMS will use a 2019's benchmark, and the practices do not have, there are no additional requirements for reporting based on beyond what the practices submit to the claims. And again, CMS will calculate this measure annually, and the measurement period is January 1st through December 31st, 2022. For risk group 3 and 4, days at home measure is a new measure, which is the claims-based measure. PCF program did release the percentile benchmark for this measure to be 320.56. And what this measure is that it measures the number of days a beneficiary stays at home or in a community setting outside of an acute care setting. And the benchmarks for this measure will be updated annually. Now, how can Persivia help you in reporting? At Persivia, we have over a decade-long experience in quality reporting. We have an expert clinical team on hand. We have had a long experience of capturing all data points and mapping and working with our clients in achieving the maximum potential for what they're doing. We have a third generation care management where we can identify workflows. We automate the workflows to identify gaps in care and then identify patients that have pending services so that the clients can go in and target the patients specifically that need care. We also assess social risk factors for the patient population, and we follow a patient across the entire continuum of care so that any gaps throughout can be pinpointed and taken care of. We also have a very nice intuitive dashboard. We have the drill down capability where you can drill down, look at individual data points for each measures, find what all needs to be taken care of for each individual patient. We also have a very good experience of reporting directly to CMS, may it be through QPP JSON files or QRDA3 file format, which would be needed for PCF program. And then let's take a look at how, if you were to work with Persivia, your dashboard would look like for PCF. All of this is drillable. You can drill down to specific data points, take a look at individual patients, and that would help you in performing great at PCF, quality gateway measures. And at this time, we can take questions and answers. Over to you, Rudy.
Thank you, Dr. Baloch. So now we'll go ahead and take some time for questions. Just as a reminder, please be sure to type your questions into the question box on your control panel if you haven't already. It looks like we have a few questions already. So the first one is, can an organization still participate if it is not located in a CPC plus region or in the states added for primary care first?
So the whole idea of releasing or mentioning the regions is that primary care first wants to make that a model population that would be a representative of the entire population for purpose of evaluation. So the answer would be no. If you're not part of the primary care first regions, participation would not be possible because it's one of the requirements of eligibility.
Okay. And then the second question we have would be, what did you mean by practice and providers in your webinar?
So a brick and mortar location is how they how PCF mentions a location, and whoever so brick and mortar location that has practitioners employed and providing care to the patients is a practice for PCF. And what do they mean by practitioner is that primary care practitioners with specialties as doctor of medicine, osteopathic medicine, nurse specialists, nurse practitioners, and physician assistants. Those would be the practitioners under a PCF program. Now, and one of the specialties is also hospice and palliative medicine. So any practice that is providing home-based service for hospice and palliative care are also part of PCF. So that's a little exception to the rule of brick and mortar location.
Okay. This third question states, I missed the information you provided for a multi-specialty practice and their eligibility for PCF. Can you please repeat?
Yes. So like I mentioned, a practice's revenue has to be 70% of the primary care revenue. So for a multi-specialty practice that would also have specialists as well as primary care providers, excuse me, the 70% of the revenue would be from the primary care providers services only. So the revenue of the entire primary care providers within the multi-specialty practice, and at least 70% of that has to come from primary care services.
Okay. The next question, how are beneficiaries attributed to a practice/provider?
Okay, so The PCF looks at the 24 months of look back period to identify which beneficiaries would be attributed to which practice and provider. There can be two ways that they do it. One is voluntary alignment. What that means is that a patient goes into Medicare website and they select a practitioner as their primary care provider. That would be the easy way. That patient would be attributed to that practitioner. However, in the absence of such alignment, what CMS PCF does is that they look at the most recent annual wellness visit or welcome to Medicare visit in the 24-month look back period, and whichever practitioner billed that would have that patient attributed to them. Now, in situations where there is no annual wellness visit, then PCF would be looking back at all the primary care services or chronic care management services that were provided in the 24-month period, and whichever practitioner had the most recent billing, they would get that patient as their attributed beneficiary. And in situations where there are multiple services provided throughout 24 months look back period, CMS will choose the practitioner that had the most recent visit billed. Now, CMS will be providing the practices with their list of attributed beneficiaries before the performance period starts, and then looking at the retrospective data before each quarter, an updated list would be shared before each quarter starts. And for that process, they'd be looking at the Medicare website for voluntary alignment on quarterly basis, and then the 24-month look back period for the alignment of beneficiaries.
Okay. This next question states, CMS website says there are only 2 cohorts and the program is not enrolling new practices. Have you heard something different?
Yes, so the enrollment for the cohort 2, which starts in January 2022, ended last year. So if someone is a part of cohort 2, they would have had filled out the applications before the year 2022 started. I will still reach out to PCF to see if there are any new advancements or new information regarding that.
All right. Next question, can PCF be reported in conjunction with MIPS, assuming a provider is reporting MIPS? What if the same ECQMs are reported to MIPS?
So for this, being a qualified QP or a partial QP comes into play, and I can give you the detailed information on that offline. But basically, if you are a QP or partial QP, you'll be participating in PCF, and but for MIPS, the eligibility is different. But I can give you the detailed information offline via email.
Okay. And then the final question that I see as of right now, how will the quality gateway measures be reported if a practice is participating in both ACO and PCF programs?
So again, so for ACO, so ACO is a different program than PCF, and the responsibility will be on the practices to report on both. So if a practice is reporting on both, they must ensure that they are meeting the reporting requirements for MSSP ACO and also PCF. So reporting on one will not fulfill the requirement of reporting on the other.
Okay. And then one just came in. I thought attribution could be based on plurality, not necessarily which provider saw the patient last.
You are correct. That is correct.
All right. And it looks like we've covered all of our questions. Is there anything else you wanted to cover before we wrap up, Dr. Fatima?
No, I'm good. Thank you.
All right, great. Thank you.